So pleasant day, dear doctors, and welcome to this examination rationalization for some infectious disease questions, which are lifted and based from two very important textbooks that covers infectious diseases, and that is Harrison's Principles of Internal Medicine, 21st edition, and Robbins and Cochran, Pathologic Basis of Disease, 10th edition. So let's start the ball rolling with some questions and talk about the rationalization. So the first question is, which of the following viruses would not be commonly identified in an immunocompetent host? If you go back to the stem of this question, the first thing that's being asked is viruses. Okay, so which of the following viruses would not be commonly identified in an immunocompetent, not an immunocompromised host? What would your answer be? Would it be herpes simplex virus, Epstein-Barr virus, varicella zoster virus, or cytomegalovirus? Correct answer here would be cytomegalovirus or CMV. Now, how would you describe the nuclei of this virus? How would you describe the nuclei of this virus? So it has the very famous description of the owl's eye appearance. Now, please do not confuse the owl's eye inclusions of cytomegalovirus with the owl's eye cells of Hodgkin's lymphoma. Would anyone happen to know what we call these cells of Hodgkin's lymphoma, which has an owl's eye appearance, or it has the appearance of mirror images? Now, these are pathognomonic of Hodgkin's, and this is what we call the Reed-Sternberg cells. These are basically the two owl's eye that I want you to keep watch for. If you hear buzzwords, or the buzzword is owl's eye. Now, this table lifted from Harrison's entitled Viruses Causing Acute Encephalitis, we have cytomegalovirus. This is in the immunocompromised host. Okay, so it's the immunocompromised host. Compromise, not competent. And in the same table, we see that herpes simplex 1 is the most common cause of sporadic encephalitis. Okay, the most common cause of sporadic encephalitis. Now, please remember these pearls. Cytomegalovirus is the most common cause of CNS infection, particularly encephalitis, in an immunocompromised host. Sporadic encephalitis is caused by herpes simplex 1. Now, which serotype of herpes simplex is the cause of genital infections? Is it simplex 1 or is it simplex 2? STDs or sexually transmitted infections. It is simplex 2. Now, the most common cause of epidemic encephalitis is West Nile virus. So again, sporadic is simplex 1. Epidemic encephalitis is West Nile virus. Now, next question. What is the common etiology of acute pyogenic meningitis in a neonate presenting with depressed sensorium, seizures, and bulging fontanelles? So they are asking for the etiology. What is the organism? They specified it's pyogenic meningitis, which is another way of saying this is bacterial in origin rather than viral or fungal. This is a neonate. Therefore, this is neonatal meningitis. Classic bulging fontanelles, which means there is increased intracranial pressure, and there's the presence of seizures. So, is this strep agalactiae, Haemophilus influenzae? Is this Neisseria meningitidis, or is this strep pneumoniae? Take note, this is a neonate. The most common cause of neonatal meningitis is strep agalactiae. Now, can you give me two other organisms that can cause neonatal meningitis? Okay, please give me two other organisms that can cause neonatal meningitis. So there's E. coli, and there is Listeria. Okay, particularly Listeria monocytogenes. These are the three common causes of neonatal meningitis, which also is the most common cause of neonatal sepsis as well as neonatal pneumonia. Now, here is a decision-making question, a very analytic question. What is the antibiotic choice for empiric treatment? When you say empiric treatment, you don't have the culture results yet. This is bacterial meningitis, and this is specifically hospital-acquired, not community-acquired meningitis. Is it A, B, C, D, or E? So based on this table entitled Antibiotics Used in Empirical Therapy of Bacterial Meningitis, please take note that in hospital-acquired meningitis, okay, a combination of ampicillin, ceftazidime, or meropenem plus vancomycin. Now, I would like to remind you that ceftazidime is given to cover more or less what hospital-acquired organism. What organism is the most common cause of nosocomial or hospital organisms? It is Pseudomonas. And why do you think vancomycin is being added? Why is vancomycin being added? What organism, which is usually hospital-acquired, are you trying to cover for? You are trying to cover for MRSA, or methicillin-resistant Staph aureus. So that is the basis for that decision. So going back to the question, the antibiotic of choice for empiric therapy of bacterial meningitis in hospital-acquired meningitis is a combination of ampicillin plus ceftazidime or meropenem plus vancomycin. Therefore, you're giving a total of 3 drugs. Next, we have another analytic case. We have an HIV seropositive. This is a 30-year-old male presenting with chronic headache. There's mucocutaneous rashes. The patient has a ataxic gait. What is your diagnosis? Headache, mucocutaneous rashes, ataxic gait, and the patient has HIV. This patient most likely has neurosyphilis. And neurosyphilis is caused by what etiologic agent? Neurosyphilis is caused by what etiologic agent? It is caused by Treponema pallidum. Okay, this spirochete, the famous spirochete that causes syphilis, Treponema pallidum. Now, don't forget of your different forms of syphilis. You have meningovascular, you have meningeal syphilis, you also have tabes dorsalis. So this patient was started on penicillin, which of course is the drug of choice of all species of treponema and all stages of syphilis. This patient, after being given penicillin, had worsening of the rashes and also developed chills, joint pains. What is the most likely explanation for the patient's symptoms? Is this SJS? Is this drug hypersensitivity? Is this Jarisch-Herxheimer? Or is this Mazzotti reaction? This, of course, is Jarisch-Herxheimer. Now, what are the most common drugs that causes SJS? Okay, number one on the list, very good. It's the sulfonamides, the sulfa drugs. Sulfonamides, particularly, number one on the list is trimethoprim sulfamethoxazole. Other drugs are the anti-epileptic drugs. What anti-epileptic drugs are notorious for causing SJS? We have phenobarbital, we have phenytoin. Okay. Phenobarbital, we have phenytoin, we have lamotrigine. And of course, third on the list for causing Stevens-Johnson syndrome would be allopurinol. Can anyone tell me what is the enzyme which is inhibited by the drug allopurinol? What is the enzyme inhibited by the drug allopurinol? It is inhibited, or it inhibits rather, the enzyme xanthine oxidase. This enzyme xanthine oxidase is the rate-limiting enzyme for uric acid synthesis. This is not drug hypersensitivity, and this is not Mazzotti reaction. Now, what two drugs are associated with Mazzotti reaction? Remember, you usually see this either in the following parasitic diseases. Yeah, onchocerca or onchocerciasis. You also see this in infections caused by loa loa. So this is associated with diethyl carbamazine, DEC. This is associated with the ingestion of DEC. So please remember this. Very good. Now next, we have a case here asking about the pathophysiology of the neurologic complications of bacterial meningitis, which is not a result of release of bacterial cell wall components and production of inflammatory cytokines. Is it the adherence of leukocytes to the cerebral capillary endothelial cells, alterations in cerebral blood flow, production of excitatory amino acids, reactive oxygen-nitrogen species, or the presence of an intact blood-brain barrier? So correct answer is an intact blood-brain barrier. Now, this is actually lifted verbatim from this algorithm from Harrison's Internal Medicine. It starts here with the invasion of the subarachnoid space by meningeal pathogens. These organisms will multiply, and these organisms will release bacterial cell wall components, particularly an endotoxin and teichoic acid. It is the endotoxin and teichoic acid which leads to the production of inflammatory cytokines. And this leads to either, number one, an altered blood-brain barrier permeability. Number two, adherence of leukocytes to the cerebral capillary endothelial cells. Number three, alterations in cerebral blood flow. Number four, production of excitatory amino acids and reactive oxygen species. The exception in the previous question is number one. Okay, it is an altered blood-brain barrier permeability, not an intact blood-brain barrier permeability. Now, what is the drug of choice for the treatment of herpes simplex encephalitis? Is it amphotericin, ganciclovir, acyclovir, or fluconazole? Now, this is herpes simplex. All herpes family except cytomegalovirus are treated with the same drug. So let's put in some common sense. Let's put in some testmanship. What is herpes? Is this a viral or is this a fungal infection? What is herpes? Is it a viral or is it a fungal infection? It is a viral infection. Therefore, the first thing you should do is eliminate the antifungal agents, which is amphotericin and fluconazole. So now you have two choices. Is it ganciclovir or is it acyclovir? Herpes simplex is treated with acyclovir. It is only cytomegalovirus of all of the herpes family which is not treated with acyclovir. Now, let's just say, for example, acyclovir is not found in the choices. Then what other alternate drug can you give to treat herpes? What other alternate drug can you use to treat herpes? So acyclovir is not in the choices. What would you look for? You look for the drug valacyclovir. Okay, so look for the drug valacyclovir. So please take note of that. Now next, this drug is not used in cytomegalovirus-associated CNS infections. This drug is not used in cytomegalovirus-associated CNS infections, okay? Is it cidofovir, ribavirin, ganciclovir, or foscarnet? Which of these drugs is not used in CMV-associated CNS infections? Correct answer is ribavirin. Now, in what viral infection would we use ribavirin? In what viral infection would you use ribavirin? Again, in what viral infection would you use ribavirin? Okay, what is its uses? Okay. The major indication for ribavirin is hepatitis C. Now, what is the mainstay in the treatment of hepatitis boy? Okay, what is the main treatment or mainstay of hepatitis boy? What antiviral Okay, when I say mainstay, it's the first line. Drugs like tenofovir can be used, but remember, there is another drug which is the mainstay, something which is more readily available in most countries. It is lamivudine. Always remember, hepatitis B, hepatitis boy, lami, lami ang boy. Lami in the Visayan dialect means masarap. Okay, this boy is hot. Therefore, what are the three drugs? I want this to come straight from you. What are the three drugs used to treat CMV-associated central nervous system infections? Number one is ganciclovir. What are the other two drugs used to treat cytomegalovirus-associated CNS infections? Make it a habit that to master things, you need to repeat things. So it's ganciclovir, cidofovir, then we have foscarnet. Now, of these three, cidofovir, ganciclovir, and foscarnet, which is a phosphate analog? Which is a phosphate analog? Is it cidofovir, ganciclovir, or foscarnet? Listen well. Which is a phosphate analog? Phosphate is foscarnet. Now, what is the etiologic agent? We're now asking for the organism that causes progressive multifocal leukoencephalopathy. This is PML. This is caused by the JC virus. Okay, this is caused by the JC virus. Okay, the JC virus. Can anyone tell me what is the other name of the JC virus? This is known as the human blank virus. Okay, what is the JC virus known as? This is also referred to as the human polyoma virus 2. Polyoma, not polio, but polyoma. Okay, polyoma virus 2. So this is actually the human polyoma virus 2. It is commonly known as the JC virus. Prions causes what CNS infection in humans? What does it cause? It causes Creutzfeldt-Jakob disease, which basically causes what we call, it causes a spongiform encephalopathy. Okay, it causes a spongiform encephalopathy. Okay, a spongiform encephalopathy. The brain degenerates and it mimics the appearance of a sponge, and microscopically, you also have the replacement of neurons with a sponge-like cell. Okay. Now, you have a 28-year-old female who was started on lamivudine, efavirenz, and tenofovir. Okay, she's already on her second month of treatment. Okay, then we have a CD4 count, which is quite low at 112. Now, what is the magic number of the CD4, cutoff CD4 for HIV? What is the magic number? That magic number is 200. Okay, that is 200. Now, would anyone happen to know what abbreviation we use for this common regimen, which involves lamivudine, efavirenz, and tenofovir? What do we call this? Okay, is it LET? Is it LTE? It is actually TLE. Okay, it's actually commonly known as TLE. Okay, that is known as TLE. Okay, and everyone knows what this term is. People living with HIV. PLHIV, that is a universally accepted medical abbreviation or acronym. Usually, the most common side effect of this treatment with TLE is usually headache. So here's the headache in the past week, but she also has suicidal ideations. So what is the most logical, immediate next step to do? Okay. Okay. It should be to order a CT scan. Okay. It should be to order a CT scan to rule out toxoplasmosis. Now, of these three drugs, which do you think is the cause of the suicidal ideations? Which do you think caused the suicidal ideations? Again, which of these three drugs of the TLE regimen do you think cause the suicidal ideations? Okay, it is what? It's the efavirenz. So very red black box warning rather of risk of suicidal behavior. Okay, risk of suicidal behavior, okay, which is associated with efavirenz. Okay. Now, question. Okay, out of the blue question. What famous anti-inflammatory drug is associated with suicidal ideations or neuropsychiatric side effects in children? Hasn't been pulled out of the market. We usually use it for asthma, hypersensitivity. Okay, that is Montelukast. Okay, Montelukast. Now, which of the following is a risk factor, a significant risk factor for invasive pneumococcal infection? Is it diabetes with an HbA1c of 6? Is it asthma, okay, an asthmatic on salbutamol? Or is a cochlear implant or a patient living with HIV? CD4 count of 500, this is pretty high, okay? So the answer here is the cochlear implant. So what organism would be associated with a cochlear implant? What organism would be associated with a cochlear implant? What organism would be associated with a cochlear implant? Okay, what organism do you think would be associated with a cochlear implant infection? Okay, or pneumococcal rather. So it's strep pneumoniae. It's the same organism that causes otitis media. Okay, it's the same organism that causes otitis media. And what is the most common organism that causes otitis externa? What is the most common organism that causes otitis externa? It's Pseudomonas aeruginosa. Now we have a 62-year-old woman, diabetic, admitted in the intensive care unit because of the following chief complaint: fever, and there's decreased sensorium. An IJ catheter, okay, so you have a foreign device there, gram-positive cocci in grape-like clusters. Coagulase positive, catalase positive. First, what organism is that? That is clearly going to be Staph aureus. But what is being asked is straight, what is the drug of choice for methicillin-resistant MRSA, Staphylococcus aureus? It is going to be vancomycin. Now, what side effect should you watch out for in vancomycin? What is a dreaded side effect? Listen well to the question. Dreaded side effect. Is red man syndrome a dreaded side effect? I don't think so. It is a side effect, but it's not a dreaded side effect. Okay, always remember vancomycin is nephrotoxic. Okay, it is nephrotoxic rather than hepatotoxic. Okay, it is nephrotoxic. That is why we usually monitor for the vancomycin trough levels. We always adjust vancomycin based on the creatinine clearance. So please take note of that. And what is that property of MRSA? Okay, that property of MRSA organisms, which increases its virulence and pathogenicity in catheters, similar to that of Staphylococcus epidermidis. It is the ability to form what? It is the biofilm formation. This helps the organism resist normal phagocytosis. So please take note of that. So we have a 12-year-old. Okay, this is a adolescent girl presenting with imbalance, visual disturbances. There's a poor vaccination history. I would put this as the buzz phrase. There's poor school performance. That means this is another red flag. There's impaired cognition. That's 1. There's ataxic gait. That's 2. There's myoclonic jerks. There's 3. So what do we call in medicine 2 or more, 3 or more symptoms? A disease that has 3 or more symptoms or 3 or more manifestations. We call that in medicine as a syndrome. Okay, so this is a syndromic disease. And here's the very specific diagnostic test, which is the ECG showing the high voltage, sharp and slow waves, which occurs at a pattern of every 3 to 8 seconds. So what is the primary clinical impression? It is SSPE, one of the chronic sequelae or complications of what virus? Okay, this is the complication of the measles virus. Okay, the complication of the measles virus. Okay, complication of the measles virus. And what inclusion bodies would you see in the brain of a patient with subacute sclerosing panencephalitis? Subacute sclerosing panencephalitis. Okay, there's an inclusion body. The Wharton Finkeldy is not seen in the brain, although it is seen in measles. So again, the Wharton Finkeldy cells, okay, are seen not in the brain. Okay, Lewy bodies, they are seen in Parkinson's. Hirano bodies, they are seen in Alzheimer's. Negri bodies, they are seen in rabies. What do we see in SSPE? Again, what inclusion bodies do we see in SSPE? What do we call those inclusion bodies? Okay, in SSPE. We call them the Cowdrey what? What is it? Cowdrey what? Is it Cowdrey A or is it Cowdrey B? Okay, is it A or is it B? Okay, it's Cowdrey A. Okay, we have the famous Cowdrey A inclusion bodies. Okay, these are also eosinophilic bodies. This is seen in the brain of SSPE. Okay, you can see this in the basal ganglia, particularly the basal ganglia. Okay, that's why there's abnormal movements in SSPE. Now, here's the rationale for this analysis and application question. This is lifted verbatim from Harrison's. SSPE is a rare and chronic progressive demyelinating disease. This is associated with the measles virus. This is going to be associated most likely in a patient with a primary measles infection at an early age, which has a mean of about 2 years. About 85% of patients, that's majority, will have symptoms between 5 to 15 years old. How old was the patient in the case? How old was the patient in this previous case? The patient was 12 years old. Now, I want everyone to remember that these are the initial manifestations as discussed in Harrison's. Number one, there's poor school performance. There's mood, personality changes. There's progressive intellectual deterioration. Going back to the previous case, there was impaired cognition and there was poor school performance. There can be the presence of either focal or generalized seizures. There's the presence of myoclonus, which was present in the case. There's ataxia, which was also present in the case. And in the late stages, the patient will be moribund, quadriparetic, bedridden, spastic. There's going to be hyperreflexia and extensor plantar responses. Question: spasticity, increased deep tendon reflex, hyperreflexia, presence of a plantar response or a Babinski. Question: is this upper motor neuron or is this lower motor neuron? This is upper motor neuron disease. Okay, now you have here a 35-year-old male. There's a 5-day history, there's fever, there's headache, vomiting, and seizures. Now, with those manifestations alone, what disease pops into your head? There's fever, there's headache, vomiting, and seizures. What is the first disease that should pop into your head? Fever, headache, vomiting, and seizures. You should think of meningitis first. Regardless of etiology, think of meningitis. Patient is now obtunded, so sensorium is down. There's irregular respirations. Okay, there is 190/100 BP. How would you interpret 190/100? As a physician, picture yourself. You are in the emergency room. You receive this patient. How would you interpret this BP of 190/100? This is simply another way of paraphrasing hypertension. Heart rate is low. There's a Brudzinski and a Kernig sign, which confirms meningeal signs. So the question here is, what reflex best describes this clinical presentation? Is this Kernohan's reflex? Is this Kussmaul's? Is this Cushing's? Or is this Gendrasik? Okay, this is obviously going to be Cushing's reflex. What is now the triad of Cushing's reflex? Triad of Cushing's reflex, which is of course indicative of increased intracranial pressure. So one, there is what? There is hypertension. There is bradypnea, or decreased respiration, or irregular respiration. Okay, then we have bradycardia. Okay, hypertension, bradypnea or irregular respiration, and there is bradycardia. Okay, widened pulse pressure is not part of the triad. Okay, although when you subtract the systolic from the diastolic, it is widened, but it is not part of the triad. So we cannot overthink, we cannot over answer So please take note of this. Now, 45-year-old man with high-grade fever. There is vomiting, headache, and chills. On the third hospital day, there's onset of petechial and purpuric rashes on both lower extremities. There is now hypotension because of bilateral adrenal hemorrhages. What is the most likely etiologic agent? This is obviously Neisseria meningitidis. Question: what is your diagnosis in this case? Okay. This is initially going to be diagnosed, okay, as Meningococcemia. You start with the primary diagnosis first. But since there is a documentation of adrenal hemorrhages, this now becomes what syndrome? It now becomes Waterhouse-Friderichsen syndrome. So again, primary diagnosis, you start with the primary diagnosis. This is meningococcemia. But if they look for the specific syndrome, it's Waterhouse-Friderichsen syndrome. Now, let me see how good you are. You should be good because you're under the master guru. What is your differential diagnosis? Okay, if I now play around with some buzzwords. First is purpura. Next, there's abdominal pain. Next, there's joint pains. Okay, and there's going to be renal failure or renal compromise. This is now going to be Henoch, Schonlein, purpura. Okay, which is of course very, very benign compared to meningococcemia. But I just wanted to play around with some buzzwords, circling around the pivot of the keyword purpura. Okay. Now, so this is Neisseria meningitidis. So this is the classic findings in meningococcemia. So you have purpuric rashes, the extremities, the trunk. Yes, it can include the face. And this is the classic example, gross picture of hemorrhages. These are the hemorrhages that you see in both adrenals. So the patient usually goes into shock. Okay. Now, what type of encephalitis typically presents with phobic spasms? Okay, phobic spasms means you're afraid. These spasms are a reaction. Okay, this is because of the larynx, pharynx, and the neck muscles contracting, along with the respiratory muscle, which is the diaphragm. And this is an attempt to swallow water. So first, what symptom is this? What symptom is being described here when there's phobic spasms? Okay, this is what we call hydrophobia, which is a classic manifestation of rabies. Okay, so this is a classic rabies encephalitis. Now, question: what is the earliest manifestation of rabies? Earliest manifestation of rabies. Okay, what is the earliest manifestation of rabies? Okay, it is numbness and tingling. Okay, around. Okay, you need to put the word around. Okay, the bite site or the site of the bite or the wound. Okay, and what do we call those inclusion bodies, which are found in the brain of rabies encephalitis? Okay, this is the nigri or the negri bodies. Please take note of that. And what is the most common sites of the brain affected Okay, brain. Most common sites of the brain affected by rabies. Give me at least two. Okay, one is going to be what? The Purkinje cells. Okay, next we're going to have we have the Purkinje cells. Then we have the mammillary bodies. Okay. Then, of course, we have a specific area which is found in the hippocampus, okay, which is known as two cells which are very uh, vulnerable to hypoxia. So we have the Ammon's horn, and we also have the pyramidal cells. Okay, the pyramidal cells and the Ammon's horn. Okay, so I hope you got that. Okay, pyramidal cells. These are all in the temporal lobe, temporal, as well as the hippocampus. Now, dexamethasone is given as an adjunctive therapy in meningitis. So these are the subjects of your STEM, DEXA, which is a corticosteroid, and we have meningitis. So what is now the rationale for administering dexamethasone 20 minutes prior? That is verbatim from the book. Okay, this is the basis in your textbook. Dexamethasone exerts its beneficial effect by inhibiting the synthesis of two very important cytokines, interleukin-1 beta and tumor necrosis factor alpha. And this is given 20 minutes before antibiotic therapy. The reason it has to be given 30 minutes before, okay, is associated with the endotoxin activation. So please take note of that. So here's the correct answer. Dexamethasone exerts its beneficial effect by inhibiting the synthesis, okay, of interleukin-1 beta. It decreases the outflow and it stabilizes the blood-brain barrier. Okay, so the answer here is all of the above. Okay, all of these are correct. Now, there's a 30-year-old woman. There's cognitive impairment. There's myoclonus. So my advice to you in testmanship is when you're taking the exam, you write the keywords at the side. This is for on-site exams. Okay, so there's cognitive impairment. You isolate and you write down, you jot down the keywords. There's myoclonus, put all of the keywords together, and there's Parkinsonism. Okay, so now they're asking for the virus. What viral infection presents with cognitive impairment, myoclonus, Parkinsonism? What virus? Okay, so this is the West Nile virus. So it is specified in Harrison's that the West Nile virus infection has sequelae. One is cognitive impairment. Two is weakness. They can also present with movement disorders such as tremors, myoclonus, and Parkinsonism. Tremors, myoclonus, and Parkinsonism. Now, the antibiotic of choice for the treatment of acute meningitis caused by a gram-positive bacilli that has a very unique motility in broth, and it's called the tumbling motility. So first, question number one, what organism are you talking about? Gram-positive bacilli that exhibits tumbling motility. This is Listeria monocytogenes. Okay, don't forget Listeria monocytogenes is associated with what food product? It is associated with what food product? It is associated with unpasteurized milk. You need to specify unpasteurized milk. It is not just any ordinary milk. It is unpasteurized milk similar to the organism Brucella. This causes what common infection in childhood or in pediatrics age group? It causes what infection in the pediatric age group? It causes neonatal meningitis. Okay, causes neonatal meningitis. And what other condition in the neonate? What other condition does it cause in the neonate? Okay, what other condition in the neonate aside from pneumonia, aside from sepsis? Okay, very good. It is granulomatosis infantisepticum. Granulomatosis infantisepticum. So going back to the case, what is the antibiotic of choice for Listeria? Okay, what is the antibiotic of choice? What is the correct answer here? Okay, it's going to be ampicillin plus gentamicin. Okay, ampicillin plus gentamicin. Now, according to this busy table from Harrison's antimicrobial therapy of central nervous system bacterial infections, here is the Listeria monocytogenes. And here is the ampicillin plus gentamicin. Okay, beautiful when you study the book. Now, which of the following CSF findings is not expected to be seen in bacterial meningitis? It's going to be an increase in lymphocytes. What would you expect? What cell, okay, would you expect to be increased in bacterial meningitis? It's not the lymphocytes, it is the neutrophils. And what are the synonyms for the neutrophils? What is the other synonym of the neutrophils? We call them the polymorphonuclears or the PMNs. Is there decreased glucose concentration? Yes. Is there increased protein concentration? Yes. Is there increased opening pressure? The answer is yes. Now look at this table lifted from Harrison's about the CSF abnormalities in bacterial meningitis. You'd expect an increase in the opening pressure. You'd expect in the WBCs, it's the neutrophils that would predominate. Glucose, okay, would basically be normal to maybe slightly decreased. Protein would be increased, okay, and that would basically be your CSF of bacterial meningitis. The most important thing here is really the white blood cells, particularly the neutrophilic predominance. Now, this is considered to be the drug of choice for meningococcal meningitis caused by susceptible strains of Neisseria meningitidis. Is it ceftriaxone, penicillin, cefotaxime, or rifampicin? Correct answer is penicillin. Okay, always be cautious about hypersensitivity. Okay, always watch out for hypersensitivity with penicillin. So in this table, okay, Neisseria meningitidis, penicillin sensitive. Okay, there goes the PenG or ampicillin. The drug of choice for chemoprophylaxis of the index case and all close contacts of uncomplicated meningococcal meningitis. Okay, correct answer is rifampin. Now, what would you expect in the body fluids of a patient receiving this RNA polymerase inhibitor, rifampin? What would you expect with the body fluids? Like the urine, the sweat, okay, it would turn orange or red-orange. And what toxicity would you expect with rifampin or rifampicin? Is it going to be hepatotoxicity or is it nephrotoxicity? Okay, this is predominantly liver. Okay, it's hepatotoxicity. In fact, it is quite hepatotoxic. So let's go over this analysis and application question because you have to remember, what do we call that hierarchy of levels of cognitive learning, which involves recall, comprehension, analysis, application, and is the backbone of the syllabus of all educators making a table of specifications or a blueprint for an exam. We call that Bloom's taxonomy. And where do you think licensure exams, particularly in the Philippines, the physician's licensure exams, as well as the Philippine Specialty Board of Internal Medicine would focus on? Would they focus more on recall, comprehension, or would they go for higher levels of cognitive learning like application, analysis, and evaluation? You think they would go for lower levels or higher levels of cognitive learning? Siyempre, they would go for higher levels of cognitive learning. So you have a 45-year-old immunocompetent female, okay, admitted for fever, headache, there's seizures, there's agitations, and here's a red flag because there is now hallucinations. What is the primary diagnostic test you would order if the consideration is a CNS infection caused by a virus caused by a virus? Would it be serologic studies and antigen detection? Would it be polymerase chain reaction or PCR? Would it be culture? Would it be an MRI and an EEG? So please take note, you would order a PCR, okay? Now, always remember, PCR is based on the concept of gene amplification. Now, in the amplification of genes, which is particularly the use of the PCR, there is a heat stable or a thermostable enzyme which is utilized for gene amplification. What is the name of that heat stable or that thermostable enzyme used in PCR? Okay, perfect. That is known as Taq polymerase. Okay, that is known as Taq polymerase, the heat stable or the thermostable enzyme. Now, lifted inheritance, the PCR has been the primary diagnostic test for herpes, CMV, Epstein-Barr, human herpes virus 6, and the enteroviruses. Look at how high the specificity is. It's roughly 99%. Okay, it is roughly 99%. So I want you to remember that. Now here, empiric therapy for a preterm infant, okay, who's less than 1 month old, and there's BACMen, there's bacterial meningitis. So first, what's the organism? What do you think the organism here is? What do you think the organism? Remember, this is a two-step question. If you want to crack the boards, you need to learn testmanship. So this is the table from Harrison's. So here is a preterm infant, okay? So if there is an infant, you would most likely be dealing with a group B beta hemolytic strep, which is represented best by Streptococcus agalactiae. So here's preterm infants, okay? Ampicillin plus cefotaxime. Once you have a term infant 1 to 3, this is now the choice of either cefotaxime or ceftriaxone. So it's the same table we asked or mentioned earlier. So this is now ampicillin plus cefotaxime. Okay, ampicillin plus cefotaxime. Now, which of the following organisms are not causes of chronic meningitis? Now, always remember, chronic meningitis is usually fungal, okay, or it is tuberculous, okay, mycobacterial. So which is not a cause of chronic meningitis? So first, is MTB a chronic meningitis? Yes or no? Yes, it is. But what's being asked here is not a cause. So this is a cause. How about Borrelia? What disease does Borrelia cause? Borrelia causes Lyme disease. And what do we call that famous rash? Okay, it's a target rash. Target or a bullseye rash, okay, of this spirochetal disease. Okay, this is known as erythema chronicum migrans. Okay, erythema chronicum migrans. Now, treponema pallidum, okay, that is, of course, syphilis. So the correct answer here, not a cause, okay, not a cause of chronic meningitis. The answer here is Listeria because that is acute meningitis. So we have here a 45-year-old woman. There's diarrhea, there's weight loss, there's arthralgias, there's fever, there's dementia, ophthalmoplegia, and oculomasticatory myoclonus. Now let us highlight what are the most important. It's a highlight. Let me box it out to make sure. I would say here, arthralgia, diarrhea, ophthalmoplegia, and a very specific oculomasticatory myoclonus. Okay, this is what disease. Give me the disease first. Okay, two-step question, perfect. Okay, this is classic Whipples disease. This is Whipples disease. Therefore, this is caused by, okay, this is caused by, of course, this is caused by trophiemia. Okay, trophiemia Whipple. Now, what is the special stain which demonstrates cryptococcal neoformans? The special stain is India ink. And what would you see in this stain? You would witness, okay, or demonstrate rather, a classic encapsulated yeast, okay? Encapsulated yeast. Now, Mycobacterium leprae has been successfully grown in this medium. Remember, it's very hard to grow in vitro, okay? So tissue culture, no. What disease do we use Petragnani medium? Okay, what organism is Petragnani medium? Okay, both Petragnani medium and LJ are used for what organism? This is used for Mycobacterium tuberculosis. So Mycobacterium leprae has been grown in this medium. This is the armadillo. So it's the footpads of mice as well as armadillo. And you see here the leonine facies of Lepromatus. leprosy. So the disease that is not attributed to Clostridium perfringens, okay, there's wound infection, pseudomembranous colitis, gas gangrene, Clostridial myonecrosis. Gas gangrene is myonecrosis, so you crash those out. And it is wound infection. What is not attributed is pseudomembranous enterocolitis. Which Clostridium species causes pseudomembranous enterocolitis? This is difficile. And what antibiotic is commonly the culprit of difficile pseudomembranous enterocolitis? It is usually clindamycin. But don't forget, aside from clindamycin, are the cephalosporins as well as the quinolones. Okay, we have ampicillin. Okay, we have amoxicillin as well. The presence of pneumatocysts on chest x-ray suggests this pathogen. Is it Klebsiella? Is it Staph aureus? Is it Pseudomonas aeruginosa? Or is it Strep pneumoniae? Okay, this is, of course, going to be Staph aureus. And pneumatocyst formation, like what you see here pointed by the red arrows, this is caused by what toxin? What toxin causes the pneumatocyst formation in a Staphylococcus aureus infection? Okay, a pneumonia in particular. Okay, it's Panton Valentine leucocidine, or PVL. Question: what pattern, okay, in the X-ray presents with the fleur-de-lis pattern? What bacteria causes a necrotizing pneumonia with the fleur-de-lis pattern? This is Pseudomonas aeruginosa. Okay, Pseudomonas aeruginosa. Now, what about this? What is the drug of choice of a patient presenting with vaginal discharges, pruritus, and this is your giveaway. This is the buzzword, strawberry cervix. First, give me your diagnosis first. Go with the process, go with the flow. Step 1, step 2, then you choose your answer. This is vaginal trichomoniasis. Okay, classic pruritus vulvae. Okay, and the strawberry cervix, trichomoniasis. So drug of choice, of course, is metronidazole. So here's the strawberry spots. This is classic. And here's the purulent vaginal discharges. Now, what if I tell you there's vaginal pruritus, but there is a cottage cheese? Cottage cheese, okay, or what we call curds of milk. Okay, curds of milk or cottage cheese. Okay, this is, of course, candidiasis or Candida albicans. Okay, please remember that. Now, anaphylactic shock from a ruptured hydatid cyst. First, what causes this hydatid cyst? Okay, this is, of course, Echinococcus granulosus. This is also known as the dog tapeworm. What does schistosoma hematobium cause? Schistosoma hematobium causes urinary schistosomiasis. What cancer is associated with schistosoma hematobium? Okay, this is associated with cancer of the urinary bladder. Okay, particularly a cancer of the urinary bladder. So please remember that. So winding up for this module, this is your hydatid cyst. Okay, so it's mass-like, space occupying. Okay, what you're afraid of is once that cyst ruptures, dude, that is going to cause anaphylactic shock. Okay, so I give you well wishes on your exams. This ends my session for today on your examination rationalization. Uh, Give me a thumbs up if you learned something. Thank you very much. This is the Master Guru, Doc Toom, saying, see you at the finish line.